Welcome to You and Your Health. I'm your host, Dr. David Bertone. Today's topic is going to be talking about a unique surgery, total shoulder replacement, which is kind of unusual to people compared to the most common joint replacement surgeries, which are the total hip and the total knee. So total shoulder is definitely a unique surgical concept that's been around for several years. And we're going to talk today about the procedure and the indications by an expert in this area. Our guest today is Dr. Allen Nicholson. Dr. Nicholson is an associate at Professional Orthopedic Associates with offices in Tinton Falls, Freehold, and Toms River. Dr. Nicholson is a graduate of Yale Medical School, did his residency at Yale Medical Center, and then did a fellowship in shoulder elbow surgery at the Hospital for Special Surgery in New York City. Dr. Nicholson, welcome to the show.
Oh, thanks for having me, Dave. Happy to be here.
Yeah, appreciate you taking the time. So just give us a little background, how you got so involved with doing this shoulder replacement surgery.
So before medical school, I actually didn't even know what orthopedic surgery was. I went to medical school and a lot of people told me, hey, we think you're going to ortho. I'm like, what is ortho? But then in clinical rotations in third year, you start rotating through the different specialties in the hospital. And I realized I absolutely love surgery. I love being able to do a procedure and actually see the results, see people actually visibly improving really usually quite quickly. And I felt that orthopedics was just the best one of those for me. I knew it was going to some sort of surgery and I just fell in love with the procedure we're able to do in ortho. So then I did residency, and then in residency, you don't really know what you want to do. I thought I wanted to go into pediatric orthopedics, but once I got exposed to shoulder replacements, arthroscopic surgery, I realized that this was the procedure, this was the specialty that would let me do arthroplasty, that's shoulder replacements, and also arthroscopy as well. And I just love doing what we do. I just love the shoulder. It's very complex. It's very interesting. The way you can address the pathology is very varied, and it's just the perfect fit for me. So.
Great, excellent. I know that the shoulder definitely is a unique joint in terms of its mobility compared to other joints in the body, and I'm sure it creates some challenges in terms of surgical intervention. But what is the most common reason somebody would have a shoulder replacement surgery?
So usually shoulder replacements are most commonly for osteoarthritis. Osteoarthritis means that you have wear and tear of the joint between the humerus and the glenoid. So the humerus is your arm bone, and it has a ball at the top, and the shoulder blade has a socket, which is called the glenoid. And between those two joints, you have a cartilage. And over time, there can be a progression of wearing and tearing out of the cartilage, and that can lead to arthritis. And that picture you just shared shows the gradual progression as arthritis develops. Basically, it's just wearing out over time. And as the joint wears out, the cartilage disappears, and you actually start to lose the joint space and develop these bone spurs from where the ball is grinding against the socket. So that's the most common reason for a regular shoulder replacement, anatomic shoulder replacement.
And what would be some of the symptoms or difficulties people would be having when they might think they might need their shoulder to be replaced?
A lot of the symptoms kind of overlap with each other. One of the most common is certainly pain, but many shoulder pathologies can cause pain, especially pain at night, pain with movement. Probably one of the symptoms more unique to osteoarthritis is really a loss of motion. And that's a loss of motion actively and passively. So even if someone else moved your arm simply can't move as far, because over time, as you get wear and tear, you start developing those osteophytes, those bone spurs. And it's kind of like a doorstop blocking a door. You simply can't move as far as you're able to. And over time, those get bigger, and then your motion gets worse and worse.
Yeah, so I'm going to put up a screen here now that shows a normal joint, an arthritic joint, and what it looks like once you replace the joint. Is this the most common scenario that you see in terms of that middle photo in terms of the arthritis?
Yeah, usually by the time patients are feeling bad enough that they come to see me for arthritis of their shoulder, it looks something like the middle picture. So you can see that they've lost the joint. It doesn't look like a ball anymore. It's kind of flattened out, and there's really no space between the ball and socket.
Yeah, so these are conditions in which your other conservative approaches have failed, I would assume, right? What typically happens with these people?
Well, oftentimes when they come to see me, some of them have already gone through conservative management, some of them haven't. Depends on if they're coming from someone like you or if they're just showing up in my office. So typically when I see them, the first thing, we take some x-rays. Usually arthritis is pretty obvious. And first we try conservative management. That's anti-inflammatory, sometimes a cortisone injection, and send them to physical therapy places like DB Ortho. And for some patients that works. And for some patients, especially if the arthritis is too severe, it's not enough. And then after we've tried conservative management, I bring them back, and then we talk about surgical management.
Okay. And so quite often there might be some other indications besides the arthritis. Can we talk about those before we talk about the specific surgeries? Say somebody has a fracture or some other indications?
Yeah, so for an anatomic shoulder replacement, that's where you replace the worn out ball with a metal ball. The primary indication is really osteoarthritis. There are other reasons to do a shoulder replacement, as you mentioned, fracture, rotator cuff tears. But nowadays, most of those other reasons when you have to do a shoulder replacement really lead to a different sort of shoulder replacement, known as a reverse shoulder replacement. So it's pretty uncommon now to have an anatomic shoulder replacement for a proximal humerus fracture, much more common to have a reverse shoulder replacement for that, as well as
Okay,
a
yeah,
rotator cuff tear.
yeah, we're gonna go into a couple of different surgical options for you. The standard anatomical replacement, right? That's one, and then a reverse replacement. And I understand that the reverse has gotten a little bit more common than it used to be, say 5 years ago. Is that accurate?
Oh yeah, there's been a huge trend towards doing reverse shoulder arthroplasty for more and more patients. The difference between those two is that the reverse is really more applicable for many pathologies. People that have rotator cuff tears that we can't fix, a reverse shoulder replacement helps them out. People that have both arthritis and a rotator cuff tear, a reverse shoulder replacement is a solution for them. People that have a proximal humerus fracture that needs to actually have surgery and are above a certain age group, usually a reverse shoulder replacement is the answer for them as well. So the indications have really expanded. These were really invented in the 1980s by a guy named Paul Grammont in France, and they came to the United States in 2004 when they FDA approved. And nowadays, they're probably more common to have a reverse shoulder replacement than anatomic shoulder replacement. There's simply more patients whose pathology fits being fixed with these than anatomic, which is a more limited and narrow window.
Okay. Yeah, so what would be a common indication for somebody to just have the anatomical shoulder replacement versus the reverse?
So pretty much an anatomic shoulder replacement is primarily for people with pure arthritis without other pathology, without rotator cuff tears, without bad bone loss, not too elderly, and patients that have better motion beforehand. And so those are the patients that nowadays are getting primary anatomic total shoulder replacements.
Right. Yeah, I mean, in physical therapy, we typically see patients with rotator cuff problems, while the osteoarthritis in the shoulder doesn't seem to be as common as the weight-bearing bones. How does that develop in the shoulder compared to the weight-bearing bones like the hip and the knee?
That's a great question. And certainly it doesn't seem to be as common. As you mentioned, you have to walk on your hip and knee. It's a weight bearing joint, but you're not walking on your shoulder. And so maybe it's there just as common. It's hard to know. I'm not really sure. Or maybe it's there and we're simply not seeing it because people aren't walking on their shoulders. As for how it develops, sometimes there's a reason. Sometimes people that I see were very active in younger life, but many times there's really no reason at all. A lot of it's just age and wear and tear. Sometimes some of it seems to be genetic. I see patients that have had their hips replaced, their knees replaced. Now they're here for their shoulders, and clearly there's a genetic component that's leading to all their joints wearing out. But some patients show up and the only thing bothering them is their shoulder, and for no discernible reason at all. So
Yeah, and I've seen people come into the office and they'll have that, crunching feeling in their joint, just like, like they might have in their hip and knee, and it just seems, so loud. And can you explain to the audience in terms of articular cartilage and that role in terms of the shoulder?
So all of our joint bearing surfaces, so our body is made up of a skeleton, which is bone. Now, between the bones glide on each other. And to have a smoothly gliding surface, you have something called articular cartilage, which is covering those surfaces. And it's kind of like Teflon on a non-stick pan. When you have an intact Teflon coating, things move smoothly, things don't stick. It's the same thing for the articular cartilage, but if the Teflon scrapes away in a pan, well, then when you cook, things start to stick. And it's the same way for the shoulder. As the cartilage goes, it starts to grind, and then you get less motion and more of that grinding, painful feeling.
Yeah, great. That's a good description of Teflon. I also explain it to the patients that it's kind of like the shiny part of the chicken leg, right? So when you get that chicken leg, you get that little shiny part up top on the bone, and that's articular cartilage, and that's what's providing that lubrication between the ball on the upper arm. And now in the shoulder, it's not really a socket; it's kind of a shelf, right? But there is somewhat of a socket that's created by some connective tissue that helps deepen the area, correct?
Yeah, we like to think of it as a golf ball on a tee, kind of a socket that the balls bounce on, and golf ball on a tee because it has to really be balanced, and that's where the rotator cuff comes in. The rotator cuff actually bounces the ball on the socket.
Okay, cool. All right, so when we come back after the break, we're going to go over the specific differences between an anatomical and a reverse shoulder replacement, and show you some images that you can see what the surgery looks like once the prostheses are put in. So we'll be right back after the break.
The COVID-19 vaccines can be our chance to get back to our plans, who we are, what we miss, to get back to each other, to life. But it's okay to have questions, like, how were the vaccines tested? In rigorous clinical trials among adults of diverse backgrounds. Can the vaccines give you COVID-19? You cannot get COVID-19 from a vaccine. Why should I get vaccinated? Protecting yourself also helps protect the people around you. Find the latest information at getvaccineanswers.org.
Get it, slip it, cuff it, check it. High blood pressure silently affects millions of Americans. Staying on top of your blood pressure is as simple as these 4 easy steps. Self-monitoring is power. Visit manageyourbp.org to learn more.
Meet the scan, a simple procedure whose mission is to detect lung cancer early.
I'm here to save you.
But I feel fine.
That's great, but you may still be at high risk for lung cancer.
Oh man, that's a new fence.
If you smoke, early detection could save your life. Learn more at savedbythescan.org.
Hi, welcome back to You and Your Health. I'm your host, Dr. David Bertone. Our guest today is Dr. Allen Nicholson from Professional Orthopedic Associates. Dr. Nicholson is an orthopedic surgeon with a fellowship training in shoulder elbow surgery. We're talking about the indications for shoulder replacement surgery. Dr. Nicholson, welcome back.
Hey, thanks for having me.
All right, so before we left, we talked about the differences, different type of surgical procedures. Let's get into specific now in terms of the anatomic versus the reverse shoulder replacement and what that might look like. And maybe you can describe it to people as I share the image on the screen.
Yeah, sure thing.
Okay.
So the picture on the left is an X-ray of what a normal shoulder looks like. And you can see the humerus, the arm bone, which has a ball on the top. And then you can see the scapula, the shoulder blade, which has a socket. And the ball sits in the socket. Now, an anatomic shoulder replacement, which we talked about beforehand, before the break, is when the cartilage between the ball and between the socket wears out. And for an anatomic shoulder replacement, it's kind of like a hip replacement. We simply remove the worn out cartilage area and we replace it with a metal ball. And where the socket is, we replace that with a plastic socket. Now, you can't see the plastic socket because the plastic is clear on the X-ray. Now, a reverse shoulder replacement has some different indications for why we do it. But basically, it's called a reverse because we actually put the ball where the socket used to go. If you look at the picture on the right, you can see that the ball is now where the socket is in the picture in the middle. So we flip it around. Now, the socket sits where the ball used to be. Now, part of that socket is metal and part of it is plastic. And you can't see the plastic part because it's clear, but it's actually cupping that ball.
Okay. So it's not a flat surface on instead of the ball. There's a little cup on that.
Yeah, there's kind of a dish that's a plastic dish that the ball is sitting around the ball.
Okay, great. Now let's go over the different indications again for using the reverse shoulder replacement, the image that was on the right. What are those indications specifically?
So for an anatomic, it's really for primary arthritis, just wear and tear of the cartilage between the glenoid and the humeral ball. Now for a reverse, the indications are much more broad. Some of the indications are if people have rotator cuff tears that have been fixed before and we can't fix again primarily. So rotator cuff re-tears is one indication. People that have rotator cuff disease and arthritis at the same time, this will fix both problems. It's for people that have bad osteoarthritis that's really worn away the bone. Sometimes over time, the arthritis can really progress and we can actually lose bone of the socket, and that can make things really much more difficult. So if you have too much wear, then a reverse is more forgiving and can solve that problem. Also for bad proximal humerus fractures, they've had a lot of studies showing that people have better outcomes. If there's an operative proximal humerus fracture, they have better outcomes with doing a reverse shoulder replacement as opposed to fixing it, or sometimes doing non-operative care. And so the last indication really for reverse is if you're doing a revision shoulder replacement. If you have to redo something, oftentimes you're redoing it and doing it to reverse.
Right, got it. Now, what about the outcomes, the difference between those that have the anatomic versus the reverse shoulder? Is there a difference in terms of how much they're going to regain in terms of function, mobility, and strength?
So both of those are very pain relieving, and both of them lead to vastly improved motion. Now, the people that get reversed in general have worse motion beforehand. And so comparatively, their motion really improves. Now, between the anatomic shoulder replacement and reverse, a reverse does have a little worse motion. So forward elevation, raising their arms straight up above their head, they maybe get about 20 degrees less, maybe to 150 degrees instead of 170. Now, what they really don't get for many people is a reverse shoulder replacement doesn't lead to as much motion behind your back. Many people can't reach up behind their back. Some people can, but the vast majority of people cannot do that very well. And that's just a limitation of the design of a reverse shoulder replacement, how the prosthesis functions.
Okay. So it's more of the design of the prosthesis than how much limitation they come in before the surgery?
Yeah, it's much more related to the design of the prosthesis than patient effort or how they were doing beforehand.
Okay. Now, in terms of the surgical process, can you just go over, is there any big differences between the surgery and how long does it take? And
so there's really, surgically, it's almost the same. I would say that an anatomic shoulder replacement actually takes a little longer. I have to do something called a lesser tuberosity osteotomy. Just you have to take a little more finesse to do it, because if you do anything slightly off, then it can fail. A reverse is more forgiving. It's easier to do. I'd say that a reverse right now is taking me about an hour to do, and an anatomic is probably taking me about 20 minutes longer.
Okay.
So,
Yeah, and I would assume there's some vital structures in those areas too, right? So you have to be cautious in terms of, when you're opening them in terms of nerves and blood supply, correct?
yeah, there's an interval. It's called the deltopectoral interval. It's an interval between two muscles that we go through to avoid damaging any nerves. Those intervals are pretty easy to avoid the neurovascular structures that we want to avoid. But to do these surgeries, to do both of them, we do have to cut one of the rotator cuff muscles called the subscapularis, and then we have to repair it back down after the surgery's over.
Yeah, and that's the muscle that helps kind of bring your hand into towards your belly, correct? That
Exactly.
muscle, yeah.
And that
And then you
muscle is
just
very critical for an anatomic shoulder replacement, but for a reverse shoulder replacement, it's really not very critical. In fact, some people don't even repair it, although I
Okay.
do.
awesome. In terms of the recovery, is it a same day procedure? Are they kept overnight, or how does that work?
So most of the time I'm doing these same day procedure. I'd say about 80%, maybe even 90% of my patients are going home. Now, if someone has medical comorbidities I'm worried about, or we have to keep a closer eye on them, we have no hesitation to keep them overnight. Or if someone's living at home by themselves and doesn't have someone to help them out, sometimes I'll keep them in overnight and then they'll go to rehab if they're in their 80s and they don't have anyone to come visit them. Sometimes we send them home even when they do live by themselves, and we simply set up a visiting nurse who'll come a few times a day and help them do whatever they need to do. But most of the time people go home.
Great. I think one of the big differences in people when they think about shoulder surgery, especially they know about rotator cuff surgery, most people are in a sling for 6 weeks. It's very limiting in terms of function. Can you explain that early on we want people to move with this procedure, correct?
Yeah, so I start physical therapy quite early. I start people in physical therapy at 2 weeks. I keep people in the sling for 4 weeks. That's what my fellowship mentors did at Hospital for Special Surgery. And I actually have my patients, I direct them to take off their sling at least a couple times a day and move their elbow, move their wrists, do some pendulums. That's where you're passively moving your shoulder around, just to avoid getting too stiff. And then we start physical therapy, and it's a guided motion very early on. And really people do quite well. These are a lot easier to rehab from than a rotator cuff. A rotator cuff, it's very critical that you don't disrupt their repair and that you're very careful. For these, you're actually able to mobilize much more quickly, and the pain relief is a lot faster than a rotator cuff repair.
Yep.
Rotator cuff repairs tend to be much more painful.
Yes, and just because of those tendon repairs and they're mobilized, and then there's that balance between not moving them and the joint getting stiff versus moving them too early and you can damage the repair, where you have a little bit more wiggle room in this procedure, correct?
Oh yeah, especially for a reverse. A reverse, you can really mobilize them quite quickly. For an anatomic, we have to be careful because we're waiting for the rotator cuff that we repaired to do the surgery to heal. So, but still they move pretty quickly.
Any bad things that can happen during these? Are there risks associated? Obviously, there's risk associated with any surgical procedure, but what are the big things that people need to be aware of that are possible?
There are some risks associated with every sort of joint replacement surgery. Now, the big one is really infection, especially with P. acnes. And we do everything we can for that. We give you antibiotics beforehand. I put antibiotics in the incision itself. And for high-risk patients, we even give them antibiotics afterwards. So that's one of the big risks. Now, the incidence of that is still quite low. We're talking like low single percents, maybe like 1 to 4%, depending on what papers you look at. And another risk is fracture during the procedure, fracture after the procedure if they have a fall while things are really healing down. And so we just have to be careful of that. Another risk, especially for an anatomic shoulder replacement, is if the rotator cuff repair doesn't take, if it doesn't heal. And if that doesn't heal, sometimes people do okay, and sometimes we have to do a revision procedure and actually convert that to a reverse shoulder replacement instead. Yeah, those are really the big ones. Other ones are standard risks related to any surgery, such as a small chance of blood clots. The chance of a blood clot is not really very high after the surgery because you don't have to walk on your shoulder and you're able to walk around just fine. So,
what do you use in determining the length of the prosthesis? I know sometimes you need to put a longer stem into the upper arm, or what's that determining factor?
So a lot of the time I go by age. I look at the bone quality. They have something called the thumb test. So prostheses have really become much shorter over time. In the old days, we were doing very long prostheses. And we've realized over time, as the technology's improved, as we've been able to do better ingrowth, because the bone actually grows into these stems, we've been able to get shorter and shorter. And these are really more bone-sparing prostheses that we do now. So the trend has really been to do what we call stemless shoulder arthroplasty now, which you can see on the left. It's not really stemless, it just has a very short stem. And so what I do is I look at their age and really I just see the quality of their bone. If their bone quality is very good, I'll do a stemless or a very short stem. And if I'm worried about the bone quality, I'll do a longer stem. And so we adjust based on what we see during surgery and based on the patient's age.
Okay. And you determine that prior to the surgery, or is that something you determine during the surgery?
So much of it is during the surgery, but before the surgery, I look at their age, I look at their x-rays, and then I tell my company that brings implants, I say, I think I'm going to need a stem of this length. But they always have kind of one above and one below, one shorter and one longer. And if we have to adjust intraoperatively, they simply bring in the other stem and then we switch it to the different length. It's really very easy to do.
Great. I can tell you, seeing these patients post-op, they do phenomenal. It's a great procedure. It's immediate relief of pain. They get function back pretty early. They're generally happy, after this procedure, compared to those unhappy people with the rotator cuff repairs and nobody told them it was going to hurt this much. And these people don't have that. So it's really a great procedure. And I got to say, it's really wonderful having somebody with your skill set down here in Monmouth County performing these, because quite often patients had to go to New York City to get this done.
Yeah, a lot of the patients I've done actually used to go to New York City for many of these surgeries, but
yeah, so now we have you close by. So great, Dr. Nicholson, we really appreciate you giving your time to explain the process of shoulder replacement surgery. And it's been an exciting show. And again, thanks for joining us.
Hey, thanks for having me. Happy to be here.
Great. Until next time, I'm your host, Dr. David Bertone, and thanks for joining us on You and Your Health.
What is it, Julia? Why are you so excited, honey?
Hey, do you want to use your talker? With Julia's autism, using a talker can help her find the words she wants to say.
My dog.
You want to do something with Rose, Julia?
Play ball.
Do you want to play catch with Rose? I think Rose is excited to play catch too. Oh, Julia, you show us so many different ways to talk together. Oh, and play. Good catch, Rose. Okay, give Julia the ball. There you go. Okay, throw the ball, Julia. Oh.
For Julia's family, early screening for autism made a lifetime of difference. Find out more at screenforautism.org.
Okay, Julia, there you go. Oh, another good throw. That's the way.
It takes less than 1 minute to find out if you may have prediabetes. You can do it here. But you probably won't. You're busy. Kids, work, show coming back in 48 seconds. So let's do this now. Hold up one finger if you're a man, women, 0. 3 more fingers if you're over 60, 2 over 50, 1 over 40. If you're not sure, keep in mind you're sitting on a couch right now, so 1 more finger if you're not very active. 1 finger if yes, 0 if no. 1 yes, 0 no. Next, find the body type that looks most like you and hold up that many fingers while I look around awkwardly. And that's it. If you're holding up 5 fingers or more, you probably have prediabetes. Sorry to be so blunt, but hey, you're busy. Just go to the site.
I don't think that many kids in my son's school even do it.
He makes fun of his friend who vapes.
He would never try it.
She's into soccer.
She's on the honor roll.
She's just not the type.
No way.
No way.
No way.
No way, my kid would never vape.
Get your head out of the cloud. Today, nearly 8,000 kids will start vaping. Maybe even yours. Learn about the dangers at talkaboutvaping.org.